Okay. Good evening, one and all present here. I am Harsha here from Science Integra, and I welcome you all for the 16th episode webinar of Maha Smiles Cleft Care for Every Child. And I would like to introduce you all to Miss Leela ma'am, who is the Senior Director of Smile Train India. Over to you, ma'am.
Thank you, Varsha. Thank you all for joining this webinar on Maha Smile. This is the result of our Smile Trend partnership with the Bajaj Finserv. And Maha Smile is a flagship program between the, like I mentioned, Bajaj Finserv and Smile Train. And our objective is to build an awareness and support the treatment for children who are born with clefts in Maharashtra. Maha Smiles will enable nearly 8,000 life-transforming cleft surgeries to children in need in Maharashtra in the period of 3 years, in the next 36 months. And main objective is to create awareness through you all about the importance of timely treatment and timeliness of the cleft treatment, and to build a referral network so that the children can avail care for the at birth itself. Like you all are taking care when the child is born, you are the first person who sees the child who's born with the cleft. So it's very important that you know what the child, where the child should be referred to. And we have a network of 11 we have 11 partner hospital in Maharashtra, and overall in India we have about 130 partner hospital. And we are the one of the world's largest cleft charity. And we are completing 25 years this year, and we have completed 20 lakh surgeries globally. So to start with, I wanted to mention that when we do this surgery, we have in our office, we have a toll-free number. So any patient or any caregiver who finds a child who needs a cleft surgery can be referred to our Smile Train Center, and they can call us on our toll-free number, and the toll-free number is 1-800-103-8301. So now I would like to introduce Dr. Supriya. She is the chairperson of AMOGS.
Wait, ma'am, I'll share the screen.
Ma'am, it's okay.
Welfare and Cultural Committee.
Yeah, we'll just put up a slide, long introduction and long achievement. So like I mentioned, Dr. Supriya Arwari, she is a consultant obstetricians and gynecologist and infertility specialist. She is the AMOGS chairperson, and she practices from Bhiwandi for last 20 years. And she's a national coordinator for TOG Adolescent Health Committee. She's also the chairperson of AMOGS, like I mentioned before. She's secretary of Thane Obstetrician and Gynecology Society. She's managing committee member of and program committee chair of Association of Medical Consultants of Mumbai. She's a past president of Indian Medical Association Bhiwandi and Bhiwandi Medical Practitioner Association. She's a founder chairman of Women's Wing of Indian Medical Association Bhiwandi. She's ex-co-chairperson of IMA Maharashtra State Committee, and she's a faculty of AICOG Mumbai 2013.
Ma'am, that's okay, fine. I'm fine.
Bangalore 2019 and Lucknow 2020, Indore 2022 and Kolkata 2023.
Thank you, ma'am. Thank you. Hello. Can I go ahead, Harsha?
Yeah, please, over to you, Dr. Supriya.
Yeah, thank you so much, ma'am. तो किसी की मुस्कुराहटों पे हो निसार, किसी का दर्द हो सके तो ले उधार, किसी के वास्ते हो तेरे दिल में प्यार, जीना इसी का नाम है. We as doctors are, programmed to bring smiles to the, on the faces of our patients. And hats off to the Smile Train initiative, which is working relentlessly to bring smiles on the faces of young children with cleft lip, cleft palate, and all associated disorders. And to take this session of Smile Train forward, it's with immense pleasure that I invite the chief guest for today, President of AMOGS, Dr. Kiran Kurtakoti. Can we flash his slides of CV? Thank you. President AMOGS, ex-chair of MPT Committee.
Supriya,
yes, I know he is not a person who needs any introduction to this august audience. What I must say is he's a leader of the masses. He has given full freedom to his team to work, and that's why I think his team is doing its best. It's really an honor to have you at the helm of affairs in AMOGS, and welcome to this session. And we would like to have some words of wisdom from you.
Yeah, at the outset, warm welcome on behalf of AMOGS to all of you. My today's guest of honors, Dr. Ajay Mane and Dr. Niranjan Chauhan, Leela ji, and of course the conveners Supriya Arwari, Pratibha Baldwa, and Monica Umbardhan. You know, really, AMOGS is really, rather than Smile Train being associated with AMOGS is proud to be associated with Smile Train, because although both of us are NGOs, okay, I feel that Smile Train is doing much more for the people of not only India, but the people of the entire world in terms of the community service that you are rendering. And today, Leela ji, you have told us that 20 lakh surgeries. I mean, this figure itself is mind-boggling, and really a very loud applause to your initiative, you know, because when two good organizations, that you and of course Bajaj, Hamara Bajaj, we all know of Bajaj, and when two good organizations come together, you know, they strike a chord between each other and of course with the community. And of course now we as AMOGS are the third organization which are going to be a part of this. So really in Marathi we call it Kharicha Vata. Okay, Kharicha Vata. I don't know what you call it in English. So Priya Hindi mein kya bolte hai mujhe nahi malum. But so whatever little bit that we can give to the organization or to the people, that we will be doing from this platform. And I really must applaud the vision of the founders of Smile Train who are behind this initiative. And I would wish you a very best of luck. And even if AMOGS contributes to one of the 8,000 surgeries that you plan to do in the next 3 years, I think it will be a proud moment for us. So thank you so much. And Supriya, I wish that I request you to get on with the program, and my best wishes. And I guess this is my 6th attendance at the Smile Train webinar. And really, I do acknowledge and appreciate the efforts of the NGO Smile Train. Thank you so much.
Thank you so much, Kiran. And thank you so much for letting us associate AMOGS with Smile Train. And we are hoping that under the banner of AMOGS and Smile Train, we can take this program not only to the corners of Maharashtra, but also to the corners of the rest of the country. Thank you so much. Next, it is again with immense pleasure that I invite my dear brother and Vice President of Foxy, Dr. Ajay Mane. Can we flash his CV?
No, Supriya. We'll skip that. No problem.
Oh, I know. Again, he is somebody that doesn't require any introduction, but a personal introduction is in order. कि ये बहनों का सच्चा भाई है. इतना तो मैं बोलना चाहूंगी कि हर बहन का और या हर भाई का सच्चा भाई है. Once he pledges his allegiance, he will go all out for you on a limb. Really appreciate that quality in you, Ajay. And over to you for your pearls of wisdom.
Thank you, Supriya. To start with, I must convey my gratitude to my brother, Dr. Kiran, who is the president of our AMOGS Maharashtra, and my co-guest of honor, Dr. Niranjan Chauhan, who is a joint treasurer Foxy. I convey my gratitude to Leela ji also, because due to her only we are conducting such kind of programs. And I'm very happy to share with Leela ji that I have personally conducted in my hospital where I was working. It was a 100-bedded multi-specialty hospital. We have conducted 2,100 surgeries of cleft lip and cleft palate with the help of government of Maharashtra in a program of school dropout children's. So in 7 years, we have conducted that. We are very happy to see the smile on the faces of those boys. So 20 lakh people you made happy. So 20 lakh families you made happy. So congratulations and thank you to you from all of us, from 20 lakh families. I convey my gratitude. Okay. And thank you very much, Supriya and Monica, for conducting such good programs for all of us. And the chairpersons, Dr. Sagar, Dr. Munalini, Dr. Amit, Dr. Kiran, Dr. Ganesh, and Dr. Rajesh, who belong to our societies. And the two speakers, I must endorse their name. Dr. Keval Patil will be speaking on imaging in cleft lip and palate, and Dr. Padma Sani. The topic is early childhood care of cleft patient nutrition and counseling. The cleft palate and cleft lip is a basic problem for the nutrition. They cannot suck the milk. They cannot engulf the milk, and everything comes out through the nose. What not? We have seen all the things, and it can be diagnosed antenatally, and it is not a reason to get the MTP done. It is to be very clear for all of us. Okay, somehow it is big taboo in our society, but with the help of good people like Smile Train and Bajaj, as Kiran said, three big social oriented good societies are working together. That is Smile Train, Bajaj, and Amox. Of course, but Amox is having a big chunk of work in such social work. So thank you all, and I am happy to be a part of this movement. So I'm very happy. Thank you very much for calling me today, and best luck for the program.
Thank you so much, Ajay. That was really sweet of you. It is now, I would like to invite the next guest of honor, who is again a very dear friend, like a brother to me, and one of the most beautiful couples of Foxy and Amox, I can say, Dr. Niranjan and Dr. Komal Chavan. We have Dr. Niranjan Chavan, who is now professor and unit chief at the LTMMC and Sion Hospital, immediate past president of MOGS, and joint treasurer of Foxy, organizing secretary of AICOG 2025. We are all
Thank you,
excited to attend.
Supriya.
And yes,
Thank you. We are all waiting for this program.
yes. So,
So, without
let me
much
make one
ado,
personal comment that I again Niranjan needs no introduction to this August gathering, but he is a true friend. He will always give attention to detail, and he'll always take the entire tribe forward with him. That is some one very beautiful quality of his, that he will never forget his dear friend somewhere left behind. Thank you so much, Niranjan. That makes you a real leader, and I'm wishing you much more accolades in future. Thank you, and over to you.
thank you so much. First of all, I would like to congratulate AMOGS, especially the Public Awareness Committee, which has done wonders. I want to take name of Dr. Monica Umberger and Supriya Albari. You are doing a wonderful job as the Public Awareness Committee and welfare and cultural committee. And of course, Kiran Kortapati being as the very nice president and Ajay Mane as the vice president 2024, being a part of AMOX as well as Foxy is going to make wonders. I would like to congratulate the Maha Smiles Cleft Care for Every Child, Leela and her team for collaborating with AMOX and TOG being one of the most important platform, number one platform for educational dissemination. And it's really heartening to hear from you the efforts which you are doing for this left children. What can I say? All of you will be enjoying the wonderful lectures and imaging, JPs and your videos, images of Dr. Keval Patil. He is going to mesmerize you from Neeraj and Dr. Padmasani Ramanan, who is going to join here and talk about nutrition, counseling for blood patients. I cannot end this, being here as a guest of honor while taking the names of esteemed chairpersons. Dr. Rajesh Kokare, who is from Baramanti, a very dear friend of mine. Dr. Amit Karade, Secretary AOGS. Dr. Kiran Sonwalkar, Secretary of Sakara Society. Dr. Ganesh Pade, President AOGS. And Dr. Murali Jalak, who is the President of Baramanti Society. And Dr. Sagar Kataria, Treasurer IME Sakara, to give their valuable time to this beautiful presentation which you all are going to go through. So without much ado, I would like the speakers to come on the dais. And Kiran, you are doing a wonderful job as AMOX, the president of about 9,000 to 10,000 gynecologists of Maharashtra, and you being the backbone and the most important person for the Foxy. We all welcome you and amongst and the office bearers on behalf of the organizing chair, Dr. Nandita Palchakar, and the scientific chair, Dr. Rishikesh Pai, to the largest Maha Kumbh Mela of AICOG, that is the obstetrician and gynecology from the world. I hope you all will have a great time in the second week of January, coming just 20 days apart. So welcome all of you and have a very great time listening this wonderful program being arranged by Amox and the Maha Smile people. Thank you so much for calling me Supriya as a guest of honor and giving me that privilege to be a part of you. Thank you.
Thank you so much, Niranjan, and all of us are extremely excited to attend AICOG 2025. Really looking forward to being in Mumbai.
Thank you.
Thank you. So let us now move forward to the scientific session. Has Pratibha joined?
Yeah, I'm here.
Yes, ma'am, she's there.
Yeah, great, great.
Very much.
So let me introduce our MOC, Dr. Pratibha Baldava. The conveners may come and go, but the MOC is constant. She's been giving her services to Smile Train continuously, and hats off to you. So may we have Pratibha's CV, please? Pratibha Baldava is, of course, well known to all the Amoxians. She is MBBS with distinction in OBGYN from esteemed KEM Hospital. Go back, please.
Supriya madam has not required. I think we'll go to the chairpersons.
Okay, fine. I think we should go ahead. And before we move forward, I would once again like to thank the organizers of Smile Train for making me and Monica and Pratibha a indivisible part of the entire experience. Thank you so much. Pratibha, over to you. Please invite the chairpersons for the next session.
Yes. Thank you so much, Supriya madam. As Supriya madam said, I am really enjoying being an indivisible part of this Smile Train program. And every time it comes, we have new speakers, some new information coming up, and it adds to our knowledge. May I invite you all to the scientific session for today. The chairpersons for today is Dr. Sagar Kataria. Dr. Sagar Kataria is a senior consultant OBGYN from Kolhapur. He heads the Kamla Hospital of Satara for the last 25 years, treasurer of IMS Satara, AMOX Zonal Conference Coordinator Zone 2. He has been the organizing chairperson for AMOX 2019 Mahablation and past president and secretary Satara OBGY. I welcome you, sir. Sagar sir, are you there? Hello?
I don't think Sagar is there. I don't think Sagar is there, but I think Kiran is there. Kiran Sonwalkar is there.
Okay. Kiran Sonwalkar, sir. Okay. Can we have the next CVs, please? Dr.
Yes,
Mrunal
ma'am. Yes, ma'am.
Yeah. Please, Harsha. Yeah.
Dr. Kiran CVs.
Okay, you can take the next CV.
Your pendant is having central cleft pendant then.
Yeah. Dr. Kiran Sonwalkar is from...
That is why I have worn it.
Dr. Kiran Sonwalkar, I welcome you, sir. Dr. Kiran Sonwalkar is the director of Sri Nursing Home Satara, secretary of Satara OBGY Society, past member of Foxy Ethical and Medical Legal Committee, past member of AMOX Medical Legal Committee, AMOX Yuva Coordinator, and worked as PCPNDT Medical Officer in Satara District Hospital. I welcome you, sir.
Thank you.
Okay, can I have the next CV, please? Dr. Ganesh Bade. Dr. Ganesh Bade is my...
Ganesh is also not there. I don't think Ganesh is there.
Also not there? But
No.
Ganesh is... I would like to introduce Ganesh as my co-houseman in Wadia Hospital. I know him very well. He's a very jolly person and now a very renowned gynecologist. And he has been the past secretary of AOGS, now president of AOGS. I welcome Ganesh if he's there. Next slide, please. Dr. Rajesh Kokre, sir. Dr. Rajesh Kokre, sir, is the immediate past president of Baramati OBGY Society and has special interest in high-risk pregnancy, IVF, infertility, and gynecological endoscopy. I welcome you, sir. I think, is Dr. Munalini Jhalak there?
No,
Dr.
I'll do
Amit
one thing. I
Sarade?
will call up Sagar Kataria to join
Yes,
and Dr. Ganesh. Meanwhile, I think since Kiran sir is there, he can start the introduction of the speaker.
yes, yes. We can
Yeah,
have the scientific session started.
yeah. Dr. Kiran, can you please introduce the first speaker for today, Dr. Keval Patil? He's going to be talking on imaging in cleft lip, cleft palate.
Uh, Hello, good evening. Dr. Keval Patil, sir, MBBS OBGYN, fetal medicine consultant and consulting obstetric gynecology in the Miraj Hospital since April 2018, successfully performing fetal intervention procedures for over 5 years, including intrauterine blood transfusion, fetal reduction, chordocentesis, amniocentesis, and CVS, managing high-risk pregnancy and providing expert consultation, offering specialized care for patients with complex fetal condition, area of expertise, management of recurrent pregnancy loss, first trimester screening, and management of uterine growth restriction. So I welcome Dr. Keval Patil, sir. Keval Patil, sir.
Hello, can you unmute, sir? Dr. Keval, sir?
Dr. Keval, your sound is muted. I don't see that you're muted, but I think there's some concern with your audio system. Is the audio plugged in properly? Just check it. No, is the audio plugged in? I mean, we know that you are saying yes, but no. The audio has to be plugged in. Audio cable has to be plugged in. Now, yeah, now you can unmute yourself.
Am I audible, sir?
Yes, now you're audible, sir.
Yes.
Yes.
Yes, you can. You are audible, sir, and you can start
Yeah.
your video as well.
At the onset, I'm very grateful and thankful to be the part of AMOX and Maha Smile initiative and be the part of the CME for cleft care for every child. I would like to convey my gratitude to our chief guest and president, AMOX Dr. Kiran Kurtkoti sir, our guest of honor, Dr. Ajay Mane sir, and Dr. Niranjan Chavan sir. I convey my gratitude and thanks to Dr. Monica Ubardhan ma'am and Dr. Supriya ma'am for inviting me to this event and to be the part of this event. So today I would like to focus upon the imaging part for cleft lip and palate and how do we approach and what are the subtle signs we need to look after to prognosticate cleft lip and palate. So cleft lip and palate and isolated cleft lip and palate are entirely two distinct entities. Now they can occur as isolated defects or as a components of chromosomal or syndromic disorders. Now the prognosis or the prognostication differs if it is isolated defect or if it is associated with any chromosomal abnormality or syndromic disorder. So definitely isolated cleft lip and palate has got a better prognosis. Just a minute. Coming to the imaging part as a part of sonologist, what do we see exactly in cleft lip and palate, or what are the entities which needs to be looked after in cleft lip and palate? Now we need to see whether it is unilateral or bilateral or whether it is a median cleft lip and palate, the type of defect, the extent of the defect, and the width of the defect. Now, the extent and the width of the defect can be seen by the anterior approach with the fetal face facing upwards. I'll come to that in my subsequent slides. Then we look after the integrity of the maxilla and the alveolar ridge, the symmetry of the nasal orifice. Now, symmetry of the nasal orifice definitely signifies because in cleft lip and palate, the side which is affected or where there is a clefting, there is a asymmetry or widening of the nasal orifice is seen in on that particular side, and there is definitely a asymmetry of nasal orifices. Coming to premaxillary protrusion, now this is seen in the mid-sagittal view, specifically seen in bilateral cleft lip and cleft palate, which results from the anterior migration of the hard palate, and it is seen secondary to the bilateral cleft lip and palate. Yeah. Now we come across into two. We have two parts of the palate. That's the primary palate as well and the secondary palate. The primary palate forms the four central incisors and extends up to the foramen incisivum. And the secondary palate basically is the hard palate, soft palate, and then the uvula. So the hard palate extends up to the nasal cavity, and the soft palate starts from the nasopharynx and extends up to the uvula. So basically, this is the primary. This is the basic anatomy which we come across, and then to the imaging part, what we see is the extent of the cleft palate is very much important, where we can know the couple about the prognosis of the fetus or the newborn. So nowadays we come across the classification which we have been using since 1995, that is Nyberg's classification, where the orofacial clefts are being classified into five types. Type 1 is cleft lip without cleft palate, that is just the lip, there is clefting in the lip. The type 2 is unilateral cleft lip and palate, where the clefting is seen from the cleft lip to the palate, hard palate, soft palate, which might extend even up to the uvula. Type 3 is bilateral cleft lip and palate, and type 4 is median cleft lip and palate, which we usually see in holoprosencephaly. And type 5 is cleft associated with amniotic band, which is very rare form and which we come across very rarely. So we'll not touch upon that part. So cleft lip and cleft palate always starts at the lip and proceeds to a different extent depending upon the extent up till the. Now, difference between cleft lip and cleft palate and isolated cleft palate is the CLCP which is there, it extends anteriorly to the soft tissue of the lip, proceeds to the hard palate, soft palate, and the uvula, while the isolated cleft palate, it starts at the uvula, that is uvula bifida as the mildest form, and proceeds along the midline in the anterior direction, affecting either only the soft palate or maybe both soft as well as hard palate. So imaging uvula is definitely important in these cases, whether it is to know whether it is associated with cleft lip and palate or only cleft palate. So what are the statistics we come across at birth is unilateral cleft lip and palate is around incidence is around prevalence is around 40%. Unilateral cleft lip around 29%, followed by bilateral cleft lip and palate around 27%, and very rarely we come across bilateral cleft lip only, which is around 5%. So now I would go into the imaging part of the ultrasound planes to diagnose the orofacial clefts, where we see routinely the facial profile in the mid-sagittal plane. Now, just a second. Yes. Here we can see the mid-sagittal plane, and in this plane, this plane definitely has got restricted imaging, in unilateral cases, but in bilateral cleft lip and palate, definitely we can rule out the palatine process. The palatine process of maxilla is seen here, the extent is seen here. And even in this is normal, where their integrity is maintained, intactness is maintained. While in bilateral cleft lip and palate, there the integrity is not maintained, and there is premaxillary protrusion of this soft tissue as well as bones. And that is what I mentioned in my previous slide. In the similar plane, we also look for another sign, that is the parallel bones, which are seen, that this is the palatine process of maxilla and this is the vomer bone. Now, these two bones which we see, they are always parallel in normal fetuses. Now, when these are not seen or when these are totally absent, we need to suspect that there is cleft palate, and we need to go into the detailing of the imaging. Now, coming to imaging of the lip, we image the nose and lip in a tangential way to see the upper lip, the intactness of the upper lip, the nasal tip, the symmetrical nasal orifices, and the lower lip and the chin. So intactness of the upper lip definitely rules out cleft lip. Coming to the premaxillary triangle, now premaxillary triangle is usually imaged in a perpendicular way, which is perpendicular to the palatine process of the maxilla to avoid the artifacts. Now the premaxillary triangle is formed by the base. This is the palatine process of the maxilla, and these are two sides of a triangle, which is the frontal process of the maxilla, and the tip is formed by the nasal bone. So considering cleft lip and palate, we need to image the base of the triangle very well. So we need to go very much perpendicular to the palatine process of the maxilla to avoid the artifacts and to misinterpret the diagnosis. Coming to the axial view, now axial view is the same view, that is the anterior approach, where when the fetus is facing upwards. Now when we go anteriorly in axial view, we first come across the maxilla. Now this is the maxilla which we are coming across. You can see the total integrity or intactness of the maxilla is seen. The soft tissue is seen, which is very much intact here. So this is totally a normal fetus, which we can rule out in this. And this should be a part of routine targeted scan, where we don't miss out on the subtle changes or subtle things, or only the isolated cleft palate, which we might miss on only in mid-sagittal plane. So here is another image where I have put on, where the intactness or integrity is not seen here, and this is bilateral cleft lip and palate. Both the soft tissue as well as the bony maxilla which is there is absent in between, and this is a case of bilateral cleft lip and palate. So because cleft lip always starts at the cleft palate always starts at the uvula, the presence of unremarkable uvula implies the presence of intact palate. If the uvula is abnormal or cannot be detected at all, this indicates a defect in the palate. Now, why we keep or stress over uvula? Because uvula, if there is isolated cleft palate with normal lip and maxilla normal, and we might miss on imaging uvula in our routine targeted scan. So it is very much important that uvula should be seen in our day-to-day targeted anomaly scan, and it should be the part of our screening process. So how do we screen uvula? So ESOG has brought into a novel marker in the diagnosis of isolated cleft palate. So in this case, we just go into the biparietal diameter section and just go distally towards the neck. So when we go distally towards the neck, we can image a free fluid filled space with equal to sign seen here, that is the uvula. And if this is seen, we can mention it as a normal and there is no cleft palate seen there. So here is a video as well. So you can see this is the equal to sign and this is the fluid filled space here. So this equal to sign is absent when there is cleft palate or when there is cleft lip and palate which is extending up to uvula. So another marker in the mid sagittal plane, I would say is not that reliable when the fetus is facing upwards with open mouth and you can see the uvula here with intact hard palate and soft palate, but it is not that ideal because you might tend to miss out due to artifacts. Now, these are the abnormal images with unilateral cleft lip and palate. Now, in the tangential section, we can see there is a significant gap in upper lip, which shows that there is a cleft lip. And when we go into the axial section, anterior approach, you can see this is the mandible. So the mandible is normal, but in case of maxilla, you can see there is a significant gap, and this is to one side, that is signifies the unilateral cleft palate as well. So the 3D scan shows the clefting on one side with premaxillary triangle. There is no base or no palatine process seen here. So there is significant gap over here, which signifies that there is a clefting over the palate. Coming to bilateral cleft lip and palate, similarly in the same views, in the mid sagittal plane, you can see the premaxillary protrusion here and the bony prominence as well as the soft tissue is protruded here, which signifies that there is bilateral cleft lip and palate. Then we can see in our premaxillary triangle view where there is definite gap over both sides on the base of the triangle. So signifies the same thing about the clefting of palate. Then over the maxilla as well as in the anterior approach, there is definitely gap on both the sides signifying, and then over the lips, upper lip, both sides, which shows cleft lip. Median cleft lip, it is very much easy when we go into a tangential plane, and when we see into tangential plane, we can, which is more to the medial, more to the midline, and this is more commonly seen in holoprosencephaly where the prognosis is little guarded. So thank you so much, and I thank everyone for giving me the opportunity to present myself on this dais. Thank you so much.
That was indeed a very insightful lecture, and it has given us an idea about what exactly do we need to look for when we are taking care of cleft lip and cleft palate. Thank you so much, Dr. Keval Patil, sir. Dr. Kiran Kurtukoti, sir, would you want to give your expert comments? And Dr. Sagar Kataria too has joined.
Yeah, Sagar has also joined. So Sagar and Kiran sir can make some comments.
Yes.
Kiran there? Sir,
I think Kiran Kurtukoti has logged out. Dr. Sagar, your special comments on this topic.
Yes, it was a wonderful talk by Dr. Keval Patil, giving insights about how to diagnose antenatally the cleft lip and palate. And there were various markers and different tricks and tips to diagnose these cases antenatally. Thank you, Keval. It was a wonderful talk. I think it will provide various tricks for all the budding OBGYN ultrasoundologists to pick up these cases early and so that we can refer them to Smile Train and get them treated. I also thank all the AMOG's office bearers and especially Supriya Arwari, Pratibha Baldava for giving me this opportunity of joining this webinar. Thank you.
Thank you so much, Sagar. Leela ma'am, you want to make any comment?
It was very interesting to see, like from the radiologist point of view, how to detect this thing. And first time I saw this, it was in Sholapur. No, sorry, it was in Sangli. It was very interesting, but I know it's very difficult to diagnose at that level. Also, you need a very high level of expertise. So that's why, whenever you come across these kind of patient, please refer them to our hospitals, because any patient, parent who come to know about that the child is going to have a cleft, there'll be a lot of anxiety, like all of us. So if you refer them to a hospital, like they can come see if the child comes, what kind of a surgery they will have and what will the result of the surgery. At least they know it is treatable and it can be taken care of. And if you see the cleft, children with the cleft are highly successful. If the cleft is not very severe, they can be very highly successful because intellectually there's nothing wrong. It's just an
Right.
aberration, a physical aberration, in their anatomy, and they can do very well in life. So it's, your support is required at that stage, like a radiologist, Dr. Keval Patil. Thank you so much for this presentation and taking us through how to
Really, really,
detect
yes.
it and
Really
all.
wonderful. And the pictures were wonderful. I mean,
Very
such
clear.
simplified. Yeah.
Yeah,
Thank you.
because
Thank you.
sometimes because it's so like whatever we've seen ourselves, you can't make out. But
Right.
having the markers going really deep and having that angle and all is like, and I was just wondering, how many anomalies are you looking at when you're doing your ultrasounds, Cleft is one of them, but like it's very like, and for the child to open the mouth,
Yeah.
it's so difficult, for you people, for the child, it so happens if the child is lying in the other direction, you can't make out, so you would miss
Absolutely.
it out and all that. But whenever you do come to know, please refer the patient. So at least we can counsel the patient and, and at least tell them if something happens, we can guide them. And if they see the children born with cleft, because most of us, when we see the child born with the cleft, we say we haven't seen it before. So we really wonder where these children are hiding because there's so much of taboo in the society. They're kept away from the society, and they're all around us,
Yeah.
Very true. Very true.
Very
So
well.
Thank you
that's
so
why
much,
we look
ma'am.
forward
Thank
to
you.
your support,
I have a
Thank you. Thank you,
question
ma'am.
for this whole panel.
Yes, Sagar.
Suppose it is diagnosed antenatally cleft lip and palate, and the mother demands for MTP. We are counseling that it is treatable and it will get easily cured afterwards. But still, if she insists on MTP, what should be our approach?
Actually, this question was taken up in our previous session when we had a medical legal, expert on board. So what the consensus is that at the end of the day, MTP is the right of the patient. And if in spite of all counseling, they insist that they want a MTP, then I think we will have to offer them. But good counseling on our part, and maybe, some like Leela ma'am said, that if they can go and meet the concerned plastic surgeons or the team of surgeons who is going to repair it for the baby in advance, maybe then their passion for keeping this baby and going for the surgery will stay alive. So I think that more or less answers the question that as an obstetrician we cannot offer MTP just on the grounds that this is a cleft lip, cleft palate, unless there are some very dangerous anomalies, serious anomalies which are lethal. Then it's a different matter. But isolated cleft lip, cleft palate, if we do counseling and they are willing to go ahead with and nowadays surgeries, many centers are offering at discounted or free cost. So that again, economic barrier should not be there. If we give them proper counseling, I think most of them will be agreeable to continue the pregnancy. But then, of course, it's their personal choice. We'll have to go with their choice.
Yes, ma'am. Positive
Yeah.
counseling is very much required in these cases, and multidisciplinary team is required. Maybe antenatal approach to a plastic surgeon and the counseling from them is very
Yes,
much
yes,
required.
very true.
I want
So
to
I
add,
think that was a yes, yes, ma'am.
Yeah, like Dr. Patil, you said, it affects the vulva, So, the speech also gets affected, So it's not only the cleft. So, we have to, when the child comes to a smile train center, they explain if it's an isolated lip or palate, one surgery is fine. Then, sometimes the nose has to be lifted because there is a gap in the gum, the ABG has to be done. And then, like there is a speech intervention is required, rehabilitation, then orthodontic rehabilitation because the bone is not there, So, and all that's, permanent intention, and it goes on, So sometimes, if the cleft is not very severe, 1 or 2 surgeries are fine. But if the cleft is severe, it could be anything between 4 to 5 surgery. And finally, the orthognathic surgery, when you're pulling in the tissue, there is a mid-phase deficiency, and there is a, so when the final surgery happens, when the child attains the puberty, the facial growth stops, then you do the final surgery and pull out the maxilla and all that, So like there are a number of, when the patient comes in, we need to counsel them. This is what's going to be happen. But the thing is, the treatment is available. The main thing is the
Right.
treatment is available.
Right.
And
So
we
that
are
is
there
the
to
thing,
give this.
madam. Yes, yes.
Very
It
true.
is an uphill task, even it cannot be the importance of the long journey that will go towards making this child near normal is going to be very tedious, and therefore, if the parents are aware, I think they will be prepared mentally also to take it
Yes.
up. And also then they have the choice if they decide that they are not financially or mentally fit to undergo all this journey, then maybe they can also have the option of MTP. But as obstetricians, as caregivers, we should always recommend that they should not consider MTP purely on this one ground of cleft lip, cleft palate. That's for certain. Thank you so much, ma'am, and a very good discussion. So I think we can now move to the next session. We have Dr. Padmasani waiting in the wings for us. And this topic actually I had brought up in the last Smile Train that, what about the feeding of the baby? Because it's not like the surgery will be done immediately after birth. And there is some time lapse between actual surgery and repair. And before that, many babies can succumb to wrong feeding habits. Actually, it has happened with my one baby, where the baby went home. Unfortunately, the mother or the relatives could not understand the correct technique, and the poor baby died of aspiration after getting home. So this is, I think, one of the very important aspects, especially for the obstetricians. So we already have our chairpersons on board. So Dr. Sagar, I think, can introduce Madam Padmasani, and we can proceed with her talk. Yes, Sagar.
Sir, you are muted. Sir, you are muted.
Sagar, please unmute yourself.
Dr. Sagar, please unmute yourself.
Yeah, sorry.
Yeah.
We are lucky to have Dr. Padmasani Ramanan here with us to give us a talk. She is a professor of Department of Pediatric, SRM Institute of Chennai. She is senior consultant at SRM Hospital and nutritional advisor on Smile Train of India. She has a membership of many bodies like Indian Academy of Pediatrics, IMA, RCOG, and she has been chairperson and co-chairperson on many different aspects of this Smile Train methods. She has been co-chair for task force on care of infants with clefts in International Cleft Conference 2017. She is a member of IAP and member of literature review team for guidelines on digital wellness and screen time. So let's hear from Dr. Padmasani Ramanan. The dais is yours, Dr. Padmasani.
Thank you, sir, for those kind words of introduction. Respected dignitaries in this webinar and organizing team, thank you so much for this opportunity. Can you all see my screen now?
Yes, ma'am, it's getting shared. Yes, ma'am. Just make it full screen, ma'am.
Yeah, I have clicked. I hope it's become full screen now.
No. Yes, it has now.
Yeah, okay. So once again, I thank you for this opportunity because I think obstetricians are among the key personnel in doing effective counseling for children with cleft. I will be speaking about early childhood care of infants with cleft, with focus on prenatal counseling and feeding. Orofacial cleft is among the commonest congenital anomalies that we encounter. It has an incidence of 1 in 700 live births. And given the birth rate that we have in India, that means 35,000 children with cleft are born every year in our country. And globally, over 2 lakh children are born with this problem. Cleft care begins from the time of diagnosis, which is often prenatal, and it continues into adulthood. And obstetrician is often the first healthcare provider for infants with cleft, followed by the pediatrician. But long-term, the cleft care should come from a multidisciplinary team consisting of professionals from plastic surgery, pediatrics, audiology, dentistry, nursing, nutrition, orthodontics, ENT, psychology, and speech pathology. I know that we had an extensive lecture, wonderful lecture by Dr. Keval, but as a clinician, we will go for a very simple classification, the Nagpur classification of clefts. Group 1 has children with only cleft lip. Group 2 has those with only cleft palate. And Group 3 has children with cleft lip and palate. And any of these groups can have a unilateral cleft, a bilateral cleft, or a midline cleft. So the components of early cleft care include counseling after a prenatal diagnosis is made and timely diagnosis at birth followed by a full assessment and care for the immediate needs, that is airway and feeding. Finally, appropriate and timely referral, helping the parents find the correct cleft care team and giving anticipatory guidance and advocacy for these patients. All these become the responsibility of the obstetrician present at the time of diagnosis. And even after the delivery, after the baby has been handed over to the multidisciplinary team, the obstetrician remains there as a liaison between the family and the cleft team, because very often you have known the family for much, much longer than the cleft team. After prenatal diagnosis, I know we had a very lively discussion about the medico-legal aspects of it. And Dr. Keval also made this point that prenatal diagnosis is usually limited to cleft lip and palate, and the status of the posterior palate is usually unknown. Once a prenatal diagnosis is made, screening for associated anomalies and syndromes is mandatory. But it is reassuring for us to learn that most infants with a cleft lip and palate do not have an underlying syndrome. It is an isolated finding. It is very important to have a frank discussion with the family, and regardless of their decision, we as healthcare providers will be non-judgmental of their decision because they are the ones who have to bring up the child and live with the child lifelong. We definitely have to give anticipatory guidance on newborn care and arrange for a prenatal consultation with the cleft and craniofacial team as early as possible. As very rightly said by many of our distinguished participants, this consultation with the cleft and craniofacial team is so important in building up the confidence of the family to manage an infant with a cleft. Whenever there is a suspicion, genetic counseling also becomes important. For the obstetrician, what is uppermost in the mind after a prenatal diagnosis is made is where to conduct the delivery of this child. Please remember that a cleft itself is not associated with a higher rate of delivery-related problems. So they do not need delivery in a high-risk obstetric unit. They're not even labeled as high risk. Most of them do very well in the newborn period. They will be able to room in with their mothers. They do not need specialized NICU care. What they need is access to appropriate feeding equipment and support. So local or regional cleft and craniofacial team staff will be able to provide this assistance even over the phone. You can conduct the delivery of these mothers without taking into consideration the presence of a cleft in the newborn, as long as the infant is not syndromic. Parents would also need information on which hospitals have the resources to support the feeding of infants with cleft lip and palate. Why is antenatal counseling so important? We have to be aware that the pros outweigh the cons. Among the pros, we have psychological preparation of the family, parental education, planned care and feeding, verification of insurance coverage whenever relevant, genetic testing. Potential for fetal surgical repair is futuristic. It is not commonly done in our country. And I would like to think it doesn't happen, but the parents can often, they should have the option of termination. The cons is, of course, increased termination and parental anxiety. Regarding postnatal diagnosis, if there is a cleft lip or a cleft lip and palate, the diagnosis is obvious. But unfortunately, an isolated cleft palate is not always identified at birth. Infants who have been discharged with an undiagnosed cleft palate often return with feeding difficulties and poor weight gain. So I would like to emphasize here that every effort has to be made to visualize the palate during the initial newborn examination in the birth hospital to exclude the presence of a cleft palate. Immediate postnatal management, highest priority is to maintain an airway. Second is establishment of feeding. Then do a head-to-toe examination for other congenital malformations. Give psychological support to the mother to encourage emotional bonding, because when the diagnosis comes as a surprise postnatally, there is definitely going to be a huge impact on the emotional health of the mother. In the midst of all this, please do not forget routine newborn care, which includes vitamin K and immunization. Critical airway obstruction at birth is seen most frequently in syndromic clefts, especially in Peary-Robin sequence. In Peary-Robin sequence, the airway is obstructed because of the micrognathia and the glossoptosis. In addition to this, there may be an associated laryngopharyngeal reflex. This airway obstruction can result in severe hypoxia and cardiac arrest. So airway management can be done by non-invasive techniques like positioning the infant in the prone position or in the side position, or by using a nasopharyngeal airway or nasal CPAP. When you're unable to maintain the airway by these non-invasive techniques, we have to consider endotracheal intubation or tracheostomy. Later surgical interventions include tongue-lip adhesions and mandibular distraction osteogenesis. But most of the children will be able to maintain their airway with non-invasive procedures. Next, and what the focus of this webinar is going to be, is successfully establishing feeding. I think somebody very rightly observed before me that feeding is a major issue in an infant born with a cleft, and it is estimated that 1 in 10 children born with a cleft lip and palate die before their first birthday. It's very, very disheartening to hear this, because these are preventable deaths. Many of these deaths occur from malnutrition due to feeding difficulties. Such a simple intervention as proper feeding instruction can make a world of difference to the survival and outcome of these infants. This is just one example of an infant seen in one of our partner hospitals a few days after birth. Birth weight was 3 kgs, but by the time the child came to the hospital, there was severe wasting and the weight had dropped to 2.04 kgs. With proper counseling, nothing else was done, no surgery, no intervention, no medication, just proper feeding, counseling, and support to the mother. The baby steadily gained weight and underwent surgical repair of the cleft at 6.4 kgs when he was in very good health without any risk. A brief word about the routine children's infant and young child feeding guidelines. All world organizations, including the World Health Organization, recommend exclusive breastfeeding for the first 6 months of life and continued breastfeeding for 2 years and beyond. The general benefits of breast milk are well known. It has benefits for the mother, it has benefits for the infant, and it has benefits for the entire community. But breast milk is particularly important for infants with cleft. The question uppermost in our minds now is it possible for children born with a cleft to get the benefits of breast milk? Why is breastfeeding important in children with cleft? Because there is a cleft, it is inevitable that whatever milk goes into the oral cavity will regurgitate into the nose. Breast milk, being a natural substance, is less irritating to the mucosa if it regurgitates. Therefore, there is less risk of ear infections. Sucking strengthens the muscles around the oral cavity, and thus it promotes better speech. The soft breast tissue can seal a cleft better than the hard bottle. There is more control over milk flow and less risk of aspiration. And finally, the act of holding the baby close to the chest and putting the baby to the chest stimulates all the 5 sense organs of the baby. And this is important for the development of an emotional bond between the mother and the caregiver and the baby. Now, what are the challenges in breastfeeding infants with a cleft? There are various types of cleft. There is isolated lip cleft, there is isolated palate cleft, and there is cleft lip and palate. For understanding the challenges that a cleft creates, we have to understand how breastfeeding works. For breastfeeding, we need a good latch and an efficient suck. This is the breast tissue with the milk glands. This is the areola and the nipple. The baby has to take the nipple, entire nipple, and a good part of the areola into the oral cavity. Efficient sucking means there should be a tight seal of the lips around the areola and an intact palate that elevates to close the nasopharynx to generate a negative pressure. In infants with a cleft, there is trouble in maintaining a good seal around the areola. Because of the cleft in the palate, you cannot close off the nasopharynx, so there is no negative pressure. So the suck is weak and non-rhythmic. Because of the gap, there is swallowing of too much of air. There is gagging and choking. Milk leaks out of the nose. The baby tires easily and is not able to nurse long enough to get the hind milk. All these will result in the mother not having sufficient milk and not having sufficient confidence to feed her baby. Can infants with a cleft take direct breastfeeding? I want all of us to, in a united voice, say yes. But here, the support of professionals experienced in feeding plays a very important role. Most babies with an isolated cleft lip can successfully breastfeed. If needed, the mother can hold the 2 sides of the lips together. But babies with a cleft lip and palate have a lower success rate for direct breastfeeding. Direct breastfeeding may still be possible if the cleft is narrow and the breast tissue is able to mold and seal the gap. A good latch is so important for efficient milk transfer. So the mother has to try various different positions. And in all these positions, the mother has to ensure that the nipple stays at the back of the tongue. All this requires someone to sit with the baby and the mother and try various techniques and build up her confidence. A good latch is when the baby's mouth is wide open and the nipple and most of the areola are inside the mouth. The lower lip is turned outward. The chin touches the breast and the mother feels no discomfort or pain during sucking. This is bad attachment where only the nipple is inside. Various positions can help in getting a good attachment for infants with a cleft. This is one such position, rugby hold, rugby or even football hold. The other hand is free to manipulate the breast tissue to achieve a good latch. This is a baby with an excellent latch. In spite of having a wide cleft lip and palate, this baby has an excellent latch when held in the rugby hold position. This is the dancer's position, where one hand supports the back of the neck and the head of the child. The other hand supports the breast tissue again and guides the chin of the infant towards the areola. Here is a mother who is feeding an infant with a cleft palate. With the dancer's position, she is able to achieve a good latch. And the third position is the modified cradle hold position. This, again, in all these positions, the bottom line is one hand should be free for the mother to guide her breast tissue in various positions. In spite of trying various positions, if they are unable to feed directly from the breast, express the breast milk and offer it to the infant. But regardless of the effectiveness of the suck, please encourage the mothers to put the baby to breast directly for 3 to 5 minutes on each side. Then express the milk and offer it to the infants. Now, why is this so important? Allowing the baby to suck directly on the breast, even when the sucking is inefficient, even when the latch is poor. This is because of this biological process. Direct sucking of the baby on the nipple of the mother helps in stimulating milk production. It helps in stimulating the let-down reflex. Prolactin is important for milk production. Oxytocin is important for milk ejection. Both are stimulated by the direct sucking action of the baby on the nipple. It helps in the development of oral motor skills. It's a source of comfort for the infant. As I said before, all the 5 senses are stimulated when the mother holds the infant close to her breast. This is important for emotional regulation and for promoting a bond between the mother and the child. But do not allow sucking for more than 3 to 5 minutes when it is inefficient, because more calories are going to get consumed and it may affect the weight gain of the baby. After you have allowed the baby to suck on the breast, teach the mother the steps of milk expression. Before expressing, the hands and the containers should be washed with warm soap and water. Then apply warm compresses on the breast and massage the breast gently. Put the baby to breast. After 3 to 5 minutes, remove the baby. Express the milk into clean containers. Completely empty one side, one breast, before moving on to the other breast. This will ensure that the hind milk, which is rich in fat, is also expressed. Finally, the expressed milk is given through appropriate feeding devices to the infant. It's very important for us to know why hind milk has to be given, because fore milk is the initial milk that comes at the beginning of each feed, whether it is direct breastfeeding or whether it is expressed. This is a watery milk which is rich in proteins and sugars, but it has a lower fat content, whereas the hind milk is thicker and more energy dense and has a high fat content. How long can you store this milk? Even though CDC has said that at room temperature you can keep for 4 hours, in our country, I'm originally from Chennai, where the ambient room temperature is 35 to 36 degrees. We do not recommend keeping it outside for 4 hours. If you are not planning on giving it to the baby immediately, put it inside the fridge. In the fridge at 4 degrees centigrade, it can be kept for 24 hours. And in the freezer, less than -4 degrees centigrade, it can be kept for as long as 6 months. We specifically recommend hand expression of breast milk because it is less expensive. There is no need to sterilize the pump equipment. It can be done anywhere. It doesn't need electricity. It does not cause discomfort. And the skin-to-skin contact is more stimulating. It will increase the milk supply for future. And this is the only way to express colostrum. Colostrum cannot be expressed using a pump because the volume is so small. But if the mother prefers to use a pump, a number of options are available in the market. Meticulous hygiene is important whenever a pump is being used. How to maximize breast milk production? Start early initiation and frequent sucking on the nipple by the infant. This is the bottom line for optimizing milk secretion. That means start expressing the milk within the first few hours when you know that the baby has been born with a cleft, because we know that a cleft baby is not going to be able to suck efficiently from the mother. And express the milk every 2 to 3 hours. Encourage skin to skin contact and apply warm compresses on the breast and massage the breast before expression. And finally, pay attention to those factors that can increase or decrease milk production. The factors that can decrease milk production include anxiety and depression in the mother, incomplete emptying of the breast, dehydration in the mother, the stress of domestic work, infrequent feeding, not feeding at night. So, assess and counsel the mother. Try to eliminate these factors that decrease milk production and focus upon those factors that can increase milk production. Support and encouragement, frequent hand expression, good hydration, sharing of household responsibilities, frequent expression, and night feeding. How to give this milk to the infants? Many common feeding devices are available. There are indigenous feeding devices like the palate. We have the nifty cup. We have the cup and spoon. We have specialized bottles. Very rarely in syndromic children, nasogastric feeding may be required. Often a combination of these devices are used by many families to feed the infant. Most of us know the indigenous devices and we are familiar with the use of palade and cup and spoon. But I want to talk about this nifty cup. This nifty cup has been specially made to meet the needs of children with cleft lip and palate. It is made from a soft silicone material that is gentle against the mouth. It is available in the market. It is available on Amazon as well. It is boilable, it is autoclavable, it is reusable. It is very convenient for us to know exactly what volume of feed the baby has taken, because there are milliliters, these gradations are there on the side of the cup. It has a reservoir here for the baby to lap the milk, so the baby can control the pace of feeding. And most importantly, from this side, the mother can directly express her milk into the cup. So she expresses it into the cup and feeds it. That way, the chances of contamination of the milk are far less. I have some feeding videos. Harsha, can you play those videos? Very
Yes,
short
ma'am.
videos.
Yes. Yeah.
Should I stop sharing?
Yes, ma'am. Is it visible, ma'am?
Yes, it's visible.
I think, Madam, paladai means what we call in Hindi as bondla. Is that correct?
I am not very familiar with the Hindi term, but
Yeah.
paladai is what the nurse here is using.
Yes,
We
that
have
is the bondla.
we have a very experienced nurse, and we often use these videos to educate our mothers as well, because they don't have the confidence how to feed with a paladai. It will choke the baby. It will go into the lungs of the baby. That is their concern. Why is the video not playing? So please note that the nurse has not dipped her finger into the milk. She is holding the sides of the paladai, and the baby is deciding the pace of feeding. So there is no risk of aspiration. Can we see the other video? The one in which the baby is drinking out of a nifty cup? This video was shared by a team in Tanzania. Dr. Barbara has shared this video with me. Here is a baby that is feeding very comfortably without choking, without gagging from a nifty cup. Thank you, Harsha. I'll go back to my presentation. Just 5 more minutes.
Yes, you can resume your presentation.
Yeah. Have you stopped sharing? I'll continue. So, in addition to deciding on which device to use, we also need to be aware of the common feeding problems to be anticipated and how to solve these problems. Nasal regurgitation is the commonest feeding problem. So please educate the families to expect it. Tell them that milk will escape through the nose. It cannot be avoided. It is common and it has to be expected. To minimize it, you can place the child in an upright semi-sitting position like this. 45 degrees. Let the baby's torso be 45 degrees to the horizontal. To some extent, gravity will help in milk flowing down into the esophagus, and regurgitation through the nose can be minimized, but it cannot be eliminated. Choking is another hazard. That is why the pace at which the milk is offered to the baby has to be slow. It has to be baby-led. Excessive air intake can cause early satiety. The infant has to be burped often. Fatigue and maternal discomfort and exhaustion. Fatigue in both the infant and the mother. These are all real issues. That is why please involve all the members of the family. Don't put the onus of feeding on the mother alone. All the family members should help in feeding, and most importantly, they should share the household work. These are the different burping techniques. The burping techniques are not different from the techniques in infants without a cleft. Whatever is comfortable for the mother, she can use. There is no single best method for feeding these infants. Each family mother-infant dyad has to try and decide what works best for them. Also pay attention to oral hygiene. It is true that infants do not have teeth till 6 to 8 months of age, but also infants do not produce much saliva in the first 2 months. And with a cleft palate, the milk will enter the nose during feeds. Breast milk does not irritate the nasal mucosa, but formula milk can leave deposits and result in a snuffy baby. So formula-fed babies will require 2 to 3 spoons of cooled boiled water after each feed to remove the deposits from the nasal airway. Once the teeth appear, they are vulnerable to tooth decay. So good oral hygiene, cutting down on sugar, and regular visits to the periodontist is essential. How to know if the baby is getting enough milk? 2 important parameters: the weight gain of the baby and the hydration status. By weight gain, I mean in the first 3 months of life, I would expect the baby to gain 30 grams per day, and in the next 3 months, 20 grams per day. And good hydration means after the first week, the baby should be able to pass 7 to 8 times clear or pale yellow urine per day. So ask the mother to count the number of wet diapers. To summarize, for successful breastfeeding, start early. Get the mother to take support from healthcare professionals, particularly lactation specialists and nursing staff. Any amount of breast milk is useful. Monitor the weight gain. Excuse me. Very important to follow up these infants after discharge. We need to have an early primary care evaluation 1 week after discharge to assess the well-being of the infant, look for jaundice, feeding problems, newborn health, and maternal and family well-being. Also try to have an evaluation by a multidisciplinary cleft team within 1 week of discharge from the birth hospital. Like all neonates, infants born with a cleft palate should also have newborn hearing screening before discharge. Sometimes these infants do not pass the hearing screening because they already have middle ear effusion, even at the time of birth. These infants would require regular audiologic evaluation and ENT assessment as part of their cleft team care. There is no difference in the timeline for introduction of complementary feeding in an infant with a cleft. Many families are scared to introduce semi-solid food when there is a cleft. They think only after repairing the palate, semi-solid food should be given. They continue to give only milk to the baby till the palate is repaired. Please counsel the parents, give them the confidence, and tell them that there is no need for you to wait for palate repair. The texture of the food needs to match the baby's stage of development. Delay in weaning will cause problems in introducing new foods. As it happens with milk, solid food can also pass into the nose of the baby and can cause sneezing. This may be distressing, but it is nothing to worry about. Finish off the meal with a drink of clear water to clean up the airway. It is important for us to know the timelines of cleft care and give anticipatory guidance to the mother without overwhelming them with too much of information. At birth, check the airway, establish feeding, assess for associated anomalies, give routine newborn care, share the treatment plan, and in some centers, pre-surgical infant feeding plates are used, not feeding plates, orthodontic plates are used. 3 to 6 months, immunize the baby according to the national schedule, monitor the weight gain, monitor the development, and lip surgery is done at 5 months. At 6 months, start giving complementary feeds. 6 to 12 months, continue with ENT assessment to rule out a middle ear effusion and refer to a pedodontist and a speech pathologist. Continue growth monitoring. Between 2.5 and 5 years, many children require speech therapy and articulation correction. Beyond 5 years, assessment and surgery for velopharyngeal dysfunction is needed for speech improvement. Between 7 and 11 years, they may require an alveolar bone graft surgery and orthodontic treatment. And in adolescents, they may require a lip nose correction and orthognathic surgery. Thank you all once again for this opportunity. I now hand over the podium back to the organizers. Happy to take questions.
Madam, that was quite insightful, especially the videos about practically telling us how to feed the babies. Sagar sir, your expert comment, please. Sagar sir? Sir, unmute yourself.
It was really wonderful talk and a lot of insight into the basics of breastfeeding and how to tackle the cleft palate baby immediately after birth up to the surgeries being done. And it was so helpful that many of unknown things were cleared, and a lot of inputs were given by Dr. Padmasani. Thank you, madam. It was a wonderful talk, and we have been enlightened about the interval period of birth and surgery, what is to be done. Thank you.
Okay. I think that was nice and concise, and both the speakers have done due justice to their topics. The chairpersons have very wisely summarized and given their keynotes and expert comments. Supriya madam, do you want to add anything?
No, I think wonderful talk by Padmasani ma'am. I think this is something that, we should make this presentation to all our staff members. What madam in her presentation, how the nurses were handling it so professionally. So that is what I think we need to train our staff how to handle such babies, and also give that information to the caregivers of that baby's family. Wonderful talk, ma'am. Really, this is something that we really needed for our obstetric day-to-day practice. Thank you so much. I think we
Thank you.
can now proceed with, if there are no more comments to be made, any questions? Pratibha, can you please take them?
Yes, yes, sure. Any questions, Harsha, in the comment box?
Harsha,
Yes, ma'am. I have shared the questions on WhatsApp with you, Pratibha, ma'am.
Yeah, yeah, I'll just have a look.
Yeah.
Okay.
Shall I put it in the chat box?
Yeah, questions. These are the questions. Just a minute. I'm just opening the. Yeah, or you can put them in the chat box here. That is also
Sure,
fine.
sure, ma'am.
Okay, how often should patients with cleft lip and cleft palate undergo follow-up imaging after surgery? That's the first question. Keval sir, can you take that?
Yes, ma'am.
How often should patients with cleft lip and cleft palate undergo follow-up imaging after the surgery is done?
After the surgery, postnatally. Yeah.
Yeah, means after the patient has
Yeah.
got the correction surgery done, do you need to get a radiology scan done? Is the question.
As per my knowledge, I don't think maybe a post surgery once imaging might be done, but no follow-up imaging is required as such for post-op cases.
Okay.
Leela ma'am, what is your take on this?
Because
Whether
as such, I
you
think the
do,
result is obvious and seen.
Yes, yes.
So I think follow-up
Leela ma'am
hardly.
needs to unmute. Leela ma'am needs to unmute.
No,
Yeah.
the post-op imaging is not required only when we're doing the orthodontic procedure. That is the time when they want to see whether the tooth is erupting or not. That is the time the imaging is. Otherwise, we don't do it because we don't want to necessarily expose the child to the X-rays and all that. So only for during the orthodontics and probably when you're doing the VPD planning, that is the time they would do it. Otherwise, for lip, palate, and all they do because when the child is on the table, the surgeon opens up the child and sees everything.
Okay. Yeah, that was okay. How do radiologists, surgeons, orthodontists, and speech therapists collaborate using imaging to plan and monitor treatment? How do radiologists, surgeons, orthodontists, and speech therapists collaborate using imaging to plan and monitor treatment?
Now,
I
basically,
think this.
yeah. Basically, ma'am, when we come across the case of cleft lip and palate antenatally, now
Yes.
we totally rely on the imaging part at present.
Okay.
So, depending upon the extent of the clefting, we counsel accordingly. But definitely, we need to see the baby postnatally, and the management may differ, but it not may differ very largely upon the postnatal findings. But to some extent, multidisciplinary team antenatally needs to be approached and the couple needs to be counseled regarding it.
Basically, what I feel that radiology gives them an idea that what procedure will they be doing after the
Yeah.
baby.
The management plan does not change as such
But yeah.
extensively. Yeah.
Okay, okay. The next question is, can imaging help predict future complications or deformities related to cleft lip and cleft palate? Can it predict future complications? Can imaging predict future complications due to surgery or deformities which will be related to cleft lip or cleft palate?
Now, imaging part, now, as I said, if it extends up to the beyond soft palate till the uvula, we might have the long-term, lifelong difficulty in swallowing or maybe regurgitation, which we even see in our antenatal scan with polyhydramnios.
Yes.
So that part can be counseled to some extent, but definitely we cannot predict the complications which can be there.
Okay, okay.
Yeah.
I just wanted to come in here and says, because it depends, the kind of primary repair the child has. It depends, a lot depends on that. If the surgery is done by
Surgical
an
outcome.
expert and VPD, so we see if the surgery is done by expert, the VPD complications are lesser. So if that's why we say, when we are talking about the Smile Train Center, our surgeon do so many surgeries. The hand is so good. So it's very important a trained professional does the cleft palate surgery.
Absolutely, ma'am.
Okay, second set of questions that we have is for question session 2. As cleft lip and palate children grow, what changes in nutrition should be considered to ensure healthy development?
The nutritional requirements of an infant with a cleft are no different from the nutritional requirement of any other normal child. That this is the point that we keep emphasizing. Their requirements are the same and their growth parameters are the same. So please follow the same infant and young child feeding practices that you would follow for any other child. Because of the challenges posed by the cleft, you may have to modify the technique. Some of the modifications which are required, we have already described in detail in the talk.
Okay. Madam, the next question for you is, are there any specific type of bottles, nipples, or feeding devices recommended for cleft patients to help with feeding? Yeah, just we discuss that the devices
I deliberately refrained from speaking about specialized bottles. There is a huge market for specialized bottles. There are various specialized bottles available for feeding these infants. But in our country, we strongly discourage bottle feeding because of the risks of contamination and gastrointestinal infections associated with poor bottle hygiene.
Okay. I think that's it. Those are the questions that we have taken them up well.
Okay, then I think that more or less summarizes everything.
Covered up most of
So if there is no more discussion, then maybe Pratibha, you can just give the vote of thanks and we can wind up the session.
Okay. Thank you so much, all the dignitaries on the dais and off the dais. The guest of honor, the President amongst Dr. Kiran Kurtakoti sir, Dr. Supriya Arwari madam for convening this session, and to the magnificent speakers, Dr. Keval Patil and Dr. Padmasani madam for giving us very nice insights on your topics. The chairpersons for being there and giving your expert comments. Thank you so much, Leela Imam madam, for your expertise and for enlightening us by giving your expert comments. Thank you, Harsha, for coordinating with us so well and not letting any technical difficulties come in between. Thank you, everyone. I really thank you from the bottom of my heart, and see you again in the next session of Smile Train. Thank you.
Thank you, and thank you, Pratibha, for always being there without fail. Thank you.
Yes.
Thank
Thank you.
Thank you.
Okay, thank you. And bye-bye,
Thank you
everybody.
all.
Bye.
Bye.
Thank you,
Good night.
everyone.
Yes, good night.
Bye.
It was a wonderful
Good night.
session.
Yes. Bye.
Bye.